Sports Talk with Jason Savage, Thursday nights at 7 on 1290 WHKY.
First Talk with Hal Row, WHKY Talk Radio.
Good morning. Welcome back to First Talk with Hal Row on 1290 WHKY Talk Radio for the Greater Hickory Metro. I'm finding out this morning that as little as 5 years ago, if you were talking about pulmonary hypertension, well, maybe there weren't a lot of treatment options. Found out that maybe there are some treatment options for certain types of pulmonary hypertension. We'll talk about that this morning with Dr. Peter Alford. He's a pulmonary medicine specialist as well as critical care and works in sleep medicine as well. Dr. Alford, thanks so much for joining us this morning.
I'm thrilled to be here, Hal.
Let's talk a little bit, first of all, about you. I always like to find out about my guests. Where are you from originally? And tell me a little bit about going to school and being a doctor.
Born and raised in Greenwood, Mississippi, but then came up to Davidson College, did my undergraduate there, went back to Mississippi, and then for medical school, and out to Baylor in Texas for my residency, and then to Bowman Gray for my pulmonary fellowship and sleep. Stayed there actually for 12 years teaching, and then went out into private practice, and have been in some form of private practice ever since.
Help me with pulmonary. I think that sometimes, I'm thinking cardio, I think heart, pulmonary, I think lungs generally. Is that what it is? Or help me with that determination?
Yes, sir. Pulmonary involves the lungs, first and foremost, but it's asthma, it's COPD, but it's also lung cancer. It's some of the more rare diseases, as well as the common pneumonias and that sort of thing. It does involve some amount of cardiology. My cardiology colleagues like to call the lungs the padding for the lungs, and the lung doctors like to call the heart the divider for the two lungs. But they are intimately connected, and I think maybe we might get into that some this hour.
Sounds good. Now, why did you just determine, out of all the options that you have in medicine, what was the determination? Did you have somebody that you knew who had asthma? Was there some personal reason, or was it just the area of practice that seemed attractive? Why pulmonary medicine?
Well, I thought I was going to be a cardiologist, but I really explored that, and in doing so, sort of became interested in the lungs. I will tell you, Al, we all go into things for different reasons. I was very inspired by some of my mentors and instructors, and was so impressed that the pulmonary guys, both in my medical school and residency, were just good all-around doctors. No, they weren't just focused on the lung. They kind of looked at the whole patient, and I was very impressed by that, and I've strived to be like that since. I think that's probably the main reason I got in there. The
lungs so very important, of course. I mean, you're not getting air in. I mean, that's one of the items. I think there's probably like three, that are just absolutely necessary to keep everything rolling, and the lungs are one of them. That's you got the heart, and of course the lungs right there at the center, kind of everything. And I think just heart, lungs, brain, pretty much what you're going to have to keep rolling.
That's very true. I like to say that, when you can't breathe, that gets your attention real quick. And something needs to be done real quick. It's sort of like chest pain or those sort of things. It demands immediate attention, and so in that respect. But the lungs are so important for us in so many different ways. I mean, just on a daily basis, we get up and sort of take them for granted, but they do so many other things besides just breathe for us. They help clean our system also. They filter things out. They produce hormones and things that are important to the function of the rest of the body. But that's getting a little too specific.
Before we wrap up this morning, maybe you can give us some healthy lung tips. And of course, we won't even get into smoking. We're not even going to talk about that. If you're smoking, stop.
We won't go there right now.
Exactly. That could be not just a whole show, but a whole morning. Let's talk a little bit about the aspect that we kind of want to focus on this morning, and that's pulmonary hypertension. Now, help us with a good definition of this that we can work with this morning. I hear hypertension, and I think, blood pressure. That's kind of what, or high blood pressure. That's normally what I think. Tell me what we're talking about when we talk about pulmonary hypertension.
Well, let me start with just a real quick anatomy lesson.
Okay.
Which is, when we talk about the heart, we usually mean the left side of the heart.
Okay.
And there's actually two sides to the heart.
Okay.
Each with two chambers. So there's 4 chambers in the heart.
Okay.
The left side of the heart is the part of the heart that pumps blood to our brain, to our muscles, to our organs.
Okay, now that is not you looking at my heart. That is my heart in the body. I look at my left side.
In your own body,
Right.
the left side
of the heart.
Left side of the heart is on your left side.
Okay.
And that is a major part of what the heart does and what we think of the heart does.
And that pumps the blood to my brain. Okay. Rest of my body.
But the important thing is it pumps oxygenated blood.
Okay.
That blood has oxygen. So before that can happen, the right side of the heart has to pump the same blood through the lungs.
Okay.
And the lungs put oxygen into the blood.
Right.
And that blood then goes into the left side of the heart, and then it goes out to the rest of the body.
Distributed it out. Okay, very good.
So the right side of the heart is actually doing the same amount of work that the left side of the heart is, but it's a different type of work. It's generally responsible for pumping the blood through vessels in the lungs that are very pliant, very it's a very low pressure type system of blood going through the delicate little lungs.
Okay.
What happens in pulmonary hypertension is that those vessels and that lung becomes hardened and constricted, and the blood going through there, it becomes more difficult to go through it, and what happens is pressure builds up, and that's what we call pulmonary hypertension, which is the right side of the heart begins to struggle, begins to strain to get that blood through the lungs into the rest of the side of the heart to do what we talked about, which is get oxygen to the rest of the body.
What causes that hardening? What are the reasons that we have that difficulty in getting that blood down into the lungs to pass through those membranes, which causes that pressure? What are the reasons for that?
Well, the list of those reasons is as long as my arm, and they're extremely varied too.
Okay.
And at some point today, we will talk about what we call idiopathic pulmonary hypertension, which basically doctor's language means we don't know what causes it.
Okay.
But the things we do know cause pulmonary hypertension include common things like COPD and emphysema. That can cause a type of pulmonary hypertension.
And we'll talk more about those reasons when we come back, a few of those reasons. We've got to get a break. Dr. Peter Alford, our guest this morning. We're talking about pulmonary hypertension, and we'll be talking a lot more about different aspects of the lungs, the heart, and ways that we can stay healthy and keep healthy lungs and a healthy heart as best we can. More First Talk right after the break. Good morning. Welcome back to First Talk with Hal Row on 1290 WHKY Talk Radio for the Greater Hickory Metro. Our guest this morning, Dr. Peter Alford. We're talking about the pulmonary hypertension. Now, when we first started talking about this, and we're talking about the right side of the heart and pumping the blood into the lungs so it can become oxygenated and then go to the left side and be pumped to our brain and throughout the rest of the body. And it's the stiffening and the hardening of those membranes, those arteries, that area that causes that back pressure, that high blood pressure, if you will, in that area of the body. Now, do I have that about correct?
That's very great. We're going to make a good doctor out of you.
Well, thank you very much. That would have been years ago if we were going to do that. But we talked about the causes. The causes are many and varied and would take us all morning long to talk about the different reasons. But there are certain things that we can do now to maybe help if we have that situation. Let's first of all talk about diagnosis. Let's talk about if someone's listening this morning and they said, pulmonary hypertension, not me, doesn't run in the family, I feel fine. But there's some symptoms and some ways that we may want to pay attention to that if we have, that may be Silent may be very difficult to determine. What's the best way to determine if we indeed do have healthy heart and lungs and we don't have pulmonary hypertension? Give me some ideas of things we better watch out for, maybe.
Well, let me say at the onset, I do not want to scare your viewers, because what I'm getting ready to say next is going to sound like something that many, many people could have,
okay.
Which is the symptoms of pulmonary hypertension are very non-specific.
Okay.
You are short of breath.
Okay.
You are fatigued. You're tired. You have trouble sleeping at night. But these, like I say, are non-specific. These could be the signs of any number of things, including just maybe being out of shape.
Right.
So when someone comes into my office and they tell me these types of symptoms, I'm short of breath, doctor, or I can't get to the mailbox without huffing and puffing.
Okay.
I will tell you, the first thing I do not think of is pulmonary hypertension. I think of the normal things. Oh, you got asthma, or you got whatever.
Okay.
But once you sort through those things, either with history taking or testing and exams, and you come up empty, then you start entertaining the possibility that someone has pulmonary hypertension. So you've got someone who's short of breath. But generally, very often, these people are young and they're maybe in very good condition, and they're usually pretty healthy type people. And so you have to get some breathing tests, and usually the breathing tests are fairly normal.
Oh, really?
And generally you'll get a chest x-ray. It usually looks pretty normal.
Okay.
So the standard things that, say, your primary care doctor would do are not going to identify the problem. And
let me ask you this before you continue on. How about an EKG?
There are some subtle findings on EKG that begin to make a pulmonary hypertension expert suspect. Okay, very good. Because that's sometimes associated with you get over 50, you go to your primary care physician, you have your yearly physical, and then that sometimes you have that EKG at that point without having to go in. You're not going through the sorting at that point. That's just one of the things the doctor likes to look at some point. And to go briefly back to an earlier point, the EKG is usually a tool that looks at the left side of the heart.
Oh, okay.
And
because we're talking about the right side.
We are talking about the right side of the heart.
Right.
And so the subtle things on EKG do show the right side of the heart, but you don't tend to look for those things.
You got to really be looking for it or think that there's something there that you need to pay attention to. I understand.
So to move forward more quickly, the main test that's going to begin to identify a lot of people with pulmonary hypertension is the echocardiogram.
Okay.
And that's an ultrasound test, very easy, non-invasive, painless type test that a lot of cardiologists would do on people. And in fact, a lot of the patients come to me with pulmonary hypertension from the cardiologist office after they've had the echocardiogram, which shows very nicely that the pressures in the right side of the heart are too high.
Okay.
And so, again, that's where we really begin to drill down into what's going on.
Now, when you have that pressure on the right side of the heart, obviously you're going to have damage, you're going to have fatigue, you're going to have. Now, I've heard of this, and I don't know if this applies in this case or not, but thickening of the wall and the buildup of muscle there, because it's having to work really hard to get that blood down into the lungs. This is part of the problems that you can have with it, right?
That is correct, but by the time you start seeing real thickening of the right side of the heart, which, as we said, usually is a much more delicate structure than the left side of the heart. By the time that wall starts getting really thick, you're very late into the disease process.
This is some of the damage and some of the late. Okay, gotcha.
Most people will have had, significant symptomatology, i.e. shortness of breath and those sort of things, much earlier than when you start seeing that type of echocardiographic change in the walls.
Now that we know a little bit about this and we've kind of defined what it is and how it works, what can we do about it? And how many people have this? Is this something that's a widespread? It seems like, to me, from what you're telling me, very difficult to diagnose. To actually get to this determination, because you're peeling back a lot of other things, everything from exhaustion to allergies to when you get to that point, what can we do about it?
Well, once you sort of determine that you're talking about pulmonary hypertension, what we used to do is put people on standard medicines that unfortunately made people maybe feel a little bit better, but did not change the course of the disease, which is a very previously it was a very depressing illness to people. Once they were diagnosed, 50% of those people were dead in 2 or 3 years.
Wow.
I mean, it was an extremely difficult disease to identify, but then once identified, difficult to treat.
Okay.
So, but what we've been able to do in the last few years is come up with some new medicines that allow us to, and we'll get into that. But prior to that, we would put people on oxygen. We would put people on fluid pills, diuretics.
Okay.
We would try to maintain an oxygen and those sort of things, decrease the pressures in the heart somewhat and relieve some of the symptoms.
Okay.
But you asked what we do. One of the things we have to do, though, is rule out some of the more common causes of pulmonary hypertension. You and I at the break are actually talking about sleep apnea.
Sure.
And sleep apnea is a good way to understand pulmonary hypertension because a person with sleep apnea during the night is struggling to breathe. Doesn't know it, they're asleep,
Right.
but they're struggling to breathe. That struggle is putting pressure on the right side of the heart.
Okay.
And it's causing, temporary pulmonary hypertension, but over and over all through the night. And if that goes on for weeks and months and years, that tightening of those vessels and relaxing, tightening, ultimately that tightening becomes permanent.
Wow.
And you can end up with a permanent form of pulmonary hypertension from your sleep apnea.
Okay.
So we would treat the sleep apnea, the pulmonary hypertension goes away, and the patient doesn't need the medicines that we'll be talking about shortly here. Yeah, so that's an example of a way you can treat pulmonary hypertension without having to go into the fancy expensive medicines or further testing or that sort of thing.
We'll talk more about that when we return. Dr. Peter Alford, our guest this morning, specialist in pulmonary medicine, critical care, as well as sleep medicine. We'll talk a little bit more about that. Maybe you're snoring or the stopping of the breathing in the middle of the night. Maybe your wife has noticed this. Maybe your husband has noticed it when you're sleeping. Find out a little bit more about sleep medicine and pulmonary hypertension. More First Talk right after the break.
.90 WHKY. Follow us on Twitter.
Good morning. Welcome back to First Talk with Hal Row on 1290 WHKY Talk Radio for the Greater Hickory Metro. Dr. Peter Alford joins us this morning, specializing in pulmonary medicine, critical care, sleep medicine, and also working with the Friar Care Physicians, a clinic, pulmonary clinic that we have. And we'll talk about that before we wrap up this morning. The need for it. And the fact that we're doing, from what you were telling me during the break, I always say we ought to air the brakes. People ought to hear what we're talking about during some pretty new technology and some cutting edge things that are happening right here in our area, which is pretty exciting. But before we do that, I want to talk a little bit about once we determine that there may be this pulmonary hypertension, that we have the diagnosis. We've peeled away some other things. We've taken a look at it. We're able to determine this. You were talking about medicines before we went to the break, and we want to talk about those briefly and some of the responses that you have from the medicines and the new medicines that we do have that are able to help with this disease.
Okay. And some of those new medicines, actually, when I say new, have been around for a while. We just didn't know how to use them or that they would work in pulmonary hypertension. But what we found out about pulmonary hypertension, that, again, back to the blood vessels that are being constricted, that there are chemicals that are in play causing that constriction and causing that constriction to be sustained. And we have found medicines that counteract those chemicals, basically. And not only that, these medicines are easy to take. It used to be that you had to be on medicines taking them literally 6 and 8 times a day,
Right.
or to have something as a constant infusion into your vein to counteract pulmonary hypertension. Now it's been boiled down to one pill
Wow.
that you take a day, or maybe one pill twice a day. And I won't go into the technical names of these medicines,
Right.
but they're made by several different companies.
Right.
They're extremely expensive, but
Okay.
they're covered by most insurance companies. And if not, these companies have been wonderful in terms of supplementing and helping out patients get these medicines. So
Are these generally the medicines that we will see that will help dilate veins, arteries at any rate? You'll have to help me here.
vasodilators.
Vasodilators, okay.
Again, you're thinking about the vessels on.
Oh, I'm thinking of the other side
left
of the heart. Okay,
Yes, yes.
gotcha.
And we tried using those medicines
Okay.
for this problem.
Because I'm thinking if they're going to use it,
Right.
in your leg,
Exactly.
they happen all over you to keep you. But no, not so much for the right side.
These
Okay.
are specifically for the
For the right-
vessels coming out of the right side of the heart.
I know you're a doctor, so it might not be for me. Just sitting here, I'm thinking, how amazing is it that we can have medicines that target just that very specific part of our anatomy, just the veins, the vessels on the right-hand side of the heart.
Right-handed, exactly. I mean, and that's been sort of the breakthrough because
That's the breakthrough. Okay.
That's part of the breakthrough because up until then, we were trying every vasodilator known to man, saying one of these things has got to work. But what would happen is we'd have to give them so much of the vasodilator for the left side of the heart vessels that they would faint or they would pass out. Your blood pressure would drop so low or whatever.
Gotcha.
And you never could get enough in to help the right side of the heart. But so we said, okay, we abandoned that approach. And we said, we just need to look at these vessels in the right side of the heart. Is there something different about them than the other vessels in the body? And they started figuring those things out. And they're still figuring them out. There's new medicines coming out about every year now. And so we're real enthusiastic about that. And to finish the point, I mentioned earlier that there was a real high mortality rate with this.
Yes, sir.
We are now seeing these lifespans go out now to 5 and 6 and 7 and 8 years now. And the beauty of that is when you buy time, then you wait for another medicine to come online or a new technique. There are surgical techniques that we're starting to realize once you've bought those 7 or 8 years. Now these patients may be candidate for, say, a lung transplant or a heart lung transplant, that sort of thing. So
it's not appropriate before at that stage, but may be appropriate.
It is appropriate now because, one, we've made these people's lives better.
Right.
And we've bought time to move on to other things or wait for that next miracle drug coming down the pipe.
And these drugs, are they usually used in tandem with other types of therapies, such as oxygen, such as trying weight loss or other types of programs to improve general health?
They are, but on the other hand, I've got a couple of patients who were on 7 or 8 different medicines and oxygen and other things, and once they go on these medicines, they leave their oxygen tank behind.
Really?
They come down off these other medicines. I mean, it's been remarkable to see the change in how we manage pulmonary hypertension now. It's a new day.
And part of that is the sleep medicine that you were talking about, because we talked about, I had a polyp. I went in. They took a look at me and they said, "You got a big neck. You're a big guy. Let's get a sleep study done on you right away," because this can help early on. If I have sleep apnea, this can help early on prevent, I'm guessing, or help if it does turn out that at one point or another there are conditions that would indicate pulmonary hypertension. This is kind of helping before that might even present or before it ever comes about.
Absolutely.
Because I have the body structure, because I have the big neck that sometimes constricts that breathing and gives the heart, especially that right side of the heart, that big workout that it doesn't need. Not a good workout, a bad workout.
Now, I do want to make sure your listeners understand that.
And I do as well, because I want to.
Well, sleep apnea, again, and I'm director of the sleep lab over at Fry.
Okay.
And so I see a lot of people coming in and out of there, and they're all shapes and sizes.
Gotcha. Okay, good.
I mean, some of the worst sleep apnea I've ever seen has been in these skinny old guys that
Gotcha, okay.
skinny young guys or whatever,
All right.
or women. But
it's not necessarily a big person.
It's not necessarily body habitus or body size that determines that. Although, as there does seem to be a threshold of body weight, which once you get over it, and if you have the right or wrong anatomy, neck size, and that sort of thing, you definitely are at higher risk for developing sleep apnea. But again, in relation to pulmonary hypertension and the sleep apnea, you treat the sleep apnea and the pulmonary hypertension goes away, and you don't need these fancy medicines. Or you treat, this may be too complex, but there's less the left heart again.
Right.
There's congestive heart failure.
Right.
If that heart failure is severe enough, it can actually back up. The pressures can back up through the lungs into the right side of the heart and cause pulmonary hypertension that way. You treat the congestive heart failure and the pulmonary hypertension goes away. So there's other ways, like we said earlier, to treat pulmonary hypertension besides these fancy medicines. But what these fancy new medicines are aimed at is the idiopathic form of pulmonary hypertension.
And you said you were going to explain that earlier, and that means
it means we don't know what causes it, but what we do know is it's not any of those other things. It's not sleep apnea. It's not left heart failure. It's not, say, scleroderma. It's not the other causes of pulmonary hypertension. It is a very specific form, and that is the type of pulmonary hypertension that responds to these medicines.
That's where the medicines come in.
Now you asked earlier, how common is this? It's not rare, but it's not common. It's an uncommon thing, and I would say for every 10,000 people I see with COPD, I see one of these pulmonary hypertension patients.
Oh, really?
And so it's not a huge problem, but it's now a treatable problem.
With these medicines?
With these medicines.
So the idiopathic form, if for lack of a better word, my understanding, can be treated with the medicine. Some of the other things that may cause this, the sleep apnea.
Hypertension in general.
We take a look at, let's take care of the sleep apnea, and we may be able to relieve the symptoms.
Yes.
Let's take a look at the problems in the left-hand side of the heart, and we may be able to take care of the problem. If not, once those all go away, then we have the medication that we can take a look at for that type that does not have the other factors contributing.
Right.
First, we got to go to a break.
Okay.
And we'll finish that thought when we come back. Dr. Peter Alford, I want to find out more about the clinic that we have here in town, the reason for that, and some of the very cool stuff going on right here on a local level with the right-hand side of the heart. Amazing stuff. More First Talk. Good morning. Welcome back to First Talk with Hal Row on 1290 WHKY Talk Radio for the Greater Hickory Metro. Dr. Peter Alford joins us this morning, and I got to tell you, when we first came in and first started talking about this, I had no idea that the right side of the heart and the left side of the heart, who thinks about that being so different and the function of either side of the heart? But pulmonary hypertension, of course, the way that you've explained it this morning, and that one particular part, that one particular side of our heart, so different than the other and the way it's responding. But you were telling me also that we have some very interesting things that are happening right here on a local level. I want to talk about the clinic. Tell me about the clinic, why it's necessary, and what's going on at the clinic. It's part of Fry.
It's part of FryCare Physicians.
FryCare Physicians.
A subunit of it that is the Pulmonary Hypertension Clinic that we sort of devote to these patients with idiopathic form. And it's necessary because, one, the complexity of going through the various algorithms of diagnosing someone and getting them to that point takes a lot of teamwork and whatever to get to that point, but also monitoring response to these medications over time and knowing when it's time to go to the next new medicine or combination and that sort of thing. And so that you see these pulmonary hypertension clinics. If you want to Google something, you can just put in pulmonary arterial hypertension, and what'll come up is the PAH Association.
PAH. Okay, gotcha.
Association. And in that website will list all the pulmonary hypertension specialists in the country,
Okay.
including my partner, Dr. William Irving, and myself. And it's a good way to kind of, if I don't know what you're listening, how far this goes out, but say if you lived in Virginia or something, and
Right.
you wanted to find a local specialist, you would go there, and they could point you to that. But the clinic is necessary, I think. And it's going to allow us to participate in a bigger data set to kind of keep up with responses, not with just our patients here in Hickory, but how people in Durham doing, how people, say in California are doing, and we can compare and know what's working and what's not working, and move forward, with and progressing this entity.
How is that monitored when you're taking a look at this and trying to gauge results and trying to gauge, well, how are you doing on this drug, or how is a patient doing under this particular test or this particular study or this? How do you? Is it through blood work?
That's a very good question, and in fact, you may be surprised by the answer. We use a lot of technology to get to the point of diagnosing and treating and figuring out, but the way we then monitor it is very simple. It's called a 6-minute walk test, and we just take a patient out, take them out in the hall, and walk them for 6 minutes. And there are a certain way of doing that,
Right.
but basically, by measuring the distance that patient is able to cover, we can just simply say, well, you know what? They're doing good. They just walked 50 more feet this week, or
Gotcha.
they're down 100 feet this week. There must be something going on. Maybe we need to check into something. And it's an extremely simplistic, low-tech way of doing it, and it works. It's been tested against much more complex ways of measuring things, and so no, there's no blood test we really need to do. I mean, we will occasionally do the chest X-ray
Right.
or this, or check the echo again, but normally that 6-minute walk is the way to follow people.
I'm going to guess, you tell me though, to stay heart healthy, to stay lung healthy, of course we know we got to quit smoking. We've talked about that on the show lots of times. But is there anything else that you could recommend? I know we got to eat better. But someone was telling me this, and I found this to be interesting. And I don't know if it applies here or not. But getting the proper amount of rest. There's certain hormones, there's certain things that happen in our body when we're getting good sleep. Now, not the stress that's put on the heart from sleep apnea. Now, we're not talking about that. But getting a good night's rest, does that apply here, or can you give me just some good general ideas for heart and lung health that we may be able to avoid some of the more clear indications of how that's developed?
Yeah, I think I can. Without going into great detail, basically everyone needs 7 or 8 hours of sleep.
Got to have it.
Now, I probably need to come back another time to explain why that is, but that we know that for sure. If you don't get 7 or 8 hours of good sleep a night, and good is something else that we need to kind of understand, but
Right.
if you don't get that 7 or 8 hours of good sleep a night, you're going to start having problems with cardiovascular issues coming up. It promotes weight gain. It causes neurological changes. It causes daytime sleepiness. It begins to affect people's work. Truck drivers begin to have wrecks. So that 7 or 8 hours is vital to both your whole body and your brain, but also the right side of your heart. That right side of the heart needs that rest every night. But also exercise. Now, I say that with reservation because of all the problems I see. Pulmonary hypertension is the one I have to be careful with. That is the one that exercise has to be done in moderation.
Okay.
And by that I mean you just can't push yourself too much, because if exercise will drive pulmonary artery pressure up if you have pulmonary hypertension. So you have to be
understand.
careful of that.
Okay.
Otherwise, you get a clean bill of health from your cardiologist. Even with left-sided heart disease, exercise is good. Asthma, good. COPD, exercise. The more exercise, the better for your lungs.
Right.
So use them, or you'll lose them.
But with the pulmonary hypertension,
You have to do that, again, in moderation. You can't push it as hard as you would, say, with some other issues. But weight loss, diet, there's no specific diet for, say, pulmonary hypertension, other than common sense, a good, well-balanced diet, because we worry about too much carbohydrates, we worry about too much fats, that sort of thing, but we need a little bit of all of that for a good, healthy lung. You need the elements within those proteins. You need those elements within those fatty acids, that sort of thing, to help the cells of your lung continue to grow and populate and stay healthy.
Now, as a physician, are you finding that more and more people nowadays, and in the medical community and your patients, are using a lot more just common sense when it comes to diet and exercise, instead of going with trying to do the immediate weight loss, trying to go on the high carb, the low carb, the high protein, the low protein? Do you find that more people are just having better results? And do you see the research saying, have a cookie every now and then, it's okay? Have green leafy vegetables. We know all these things. We just need to apply them without trying to trick the body.
I think so, Hal. I have not, and this is going to disappoint your listeners, but there is no quick fix out there, and so you have to adopt a lifestyle and a diet plan that will slowly get the weight off. Because if you do one of these fad diets and get that 20-30 pounds off real fast, it is even more likely that weight's going to come back and then some.
With a vengeance. It's going to come back mad.
The faster it goes off, the easier and faster it'll come back.
We need to wrap up this morning, but real quick, I want to make sure I have the phone number right. 828-322-2005. If we have questions regarding what we heard this morning or anything that they'd like to talk about more in depth, is that correct?
That is correct. That'll get you into the FryCare Pulmonary Clinic.
FryCare Pulmonary Clinic, 322-2005. Dr. Alford, thanks so much for joining us this morning. It's been very enlightening. I thank you for your time, and thanks for some great information this morning.
Thank you, Hal.
We're going to go ahead and close the way we normally do with our national anthem. Thanks so much for joining us on First Talk. We know you have a choice in morning radio. That's why we appreciate you choosing the First Talk radio program. Our guest this morning has been Dr. Peter Alford. We've been talking about pulmonary hypertension. If you want more information, call 828-322-2005, 828-322-2005. Always taking your guest suggestions, topics. Email us, talk@WHKY.com. Listen live at WHKY.com. And join us tomorrow, 7 to 9, for First Talk with Hal Row, right here on 1290 WHKY Talk Radio for the Greater Hickory Metro. Be grateful for what you got. Make it a great day. We'll talk tomorrow.